Morning, everyone. Those of you who are joining online and those brave but hardy few that are here in the auditorium joining us live. We have a very special visitor today, Dr. James Kirkland from the Mayo Clinic. And we're going to hear about something I think all of us have a vested interest in, and that is understanding the aging process and understanding it, possibly modulating the aging process to increase a healthy lifespan. Dr. James Kirkland was the first to develop senolytic drugs. That's what we'll be talking a little bit about today, senolytic drugs that destroy senescent cells. He's done fundamental work in aging, the mechanisms of aging, and the alterations in metabolism and adipose tissue with aging. He's done some very nice translational work in increasing the health span, lifespan in animal models, showing that these agents, senolytic agents, can increase lifespan and also reduce age-related diseases. And those ideas that he's developed are now undergoing rigorous testing. We were talking last night. He has been involved either developing himself or contributing to over 40 trials right now, clinical trials going on with senolytic drugs. So we're going to be getting some answers pretty soon. He's principal investigator of the Translational Neuroscience Network. That's an NIH-funded network that brings together academic institutions that are interested in translating health span interventions. He's also president of the American Federation for Aging Research. He's a board-certified specialist in internal medicine, geriatrics, endocrinology, and metabolism. And in, just a couple of years ago, he was the recipient of the Irving Wright Award of Distinction from the American Federation of Aging Research. And he's published over 225 papers in aging research, and he's going to share his wisdom with us today. Dr. James Kirkland, please come up and take the podium.
Thank you very much, Dr. Cook, and everybody for turning up. And I hope I don't say anything too stupid or presumptuous or anything like that, but we'll get started. So by way of disclosures, I was a scientific founder of a company, Senescence, that later became Unity, but by law now, because I'm involved in clinical trials, I can't be involved in any companies or owning founder shares or consulting beyond certain limits. So those things are past history now. So I think I've never had a patient come to me as a geriatrician and ask to live longer. They come to me and they ask, can I be independent, healthy, free of disease, free of disability? And I started off as a clinical geriatrician, and I got tired of prescribing better wheelchairs, walkers, and incontinence devices. So I went back to school to see if there's something more fundamental that potentially could be done about this. And that was back in the days when there was really nothing or no thought about medical interventions for the geriatric syndromes. And since then, I think the field has come to understand that what most individuals want, except for a few 20-year-olds who want to live to be 200, what most people want is to extend the period of health span, the period during life when people are free of disability, pain, are independent, are able to still work if they want, and not have cognitive dysfunction. So there are many things that can, by the way, aging begins before conception. Down syndrome turns out to be a cellular senescence, at least in part driven disorder. So the group at MIT found this out a year ago. So aging the oocyte before it's even fertilized can contribute to syndromes. And there are many diseases and disorders, as I'll show you, in children, right through to late adulthood that are related to fundamental aging processes. So these processes begin at or arguably even before conception. And they're occurring in all of us right now. The rate at which they occur can be accelerated or slowed down by various things in observational studies, like the kinds of dietary intake, things like growth hormone and insulin and IGF-1 can accelerate these processes. And there are many other things. There's a list of 70, 80 things that have been linked epidemiologically at least, or in experimental studies, to the rate at which some of these processes occur. There's a limited number of processes that seem to predispose and be upstream root cause contributors to multiple things that occur with aging. So these include the geriatric syndromes that I mentioned, things like falling, incontinence, malcognitive impairment, and a range of other conditions. A lot of chronic diseases. It's turning out many acute diseases now are related to fundamental aging processes, and decreased physical resilience, or ability to respond to a stress, for example, to mount an antibody response to a flu vaccination or recover after surgery. So an intervention point is where these fundamental aging processes occur, and this is the so-called geroscience hypothesis, that these fundamental aging processes may be root cause contributors to the bulk of conditions that cause most morbidity, mortality, and health expenditures. And that was put forth by Gordon Lithgow back more than 20 years ago, and then Felipe Sierra, Brian Kennedy, and others popularized it. So you can divide these aging processes, fundamental aging processes, or pillars of aging, into anywhere from 4 to 15 plus groups. I'm not a very smart person. I like to categorize them into 4 categories by way of simplicity. They're highly interconnected, such it appears, and we call that the unitary hypothesis of fundamental aging processes, such that if you target one or accelerate one, you tend, but it's not completely proven yet, to affect all the rest. So I'm going to focus on cellular senescence, which is one of these processes, but I could equally well be talking about the others because they're so highly interconnected. So thinking simply, I'll talk about cellular senescence in more detail. Another thing that tends to occur when fundamental aging processes are operative, say in phenotypes in older individuals or at sites of multiple diseases from before birth on, include chronic low-grade sterile, that is in the absence of known bacteria, fungi, viruses, inflammation that tends to be linked to fibrosis. Another group of processes is a big basket of things involving macromolecular and organelle dysfunction, so things that occur with DNA, like DNA damage foci within telomeric ends, single-strand breaks, epigenetic changes, etc. Things occur with sugars, with increases in reducing sugars that react with amino groups on proteins and DNA backbones and affect their stiffness and structure. There are changes that occur with lipids, with increases in saturated lipids, ceramides, bradykines, prostanoids of various types, and things that occur with proteins, especially with increases in protein production, actually, in many of these tissues, but failed autophagy, and then proteins that hang around and can aggregate or be misfolded. So accumulation of things like tau, beta amyloid, alpha-synuclein. Then there are changes in organelles. I won't go through them all, but every kind of organelle within a cell, from the nucleus to mitochondria to lysosomes, undergo change in function. Then there's stem cell. I don't like calling them stem cells because to me a stem cell gives rise to a baby. I like calling them progenitor cells. But there are changes in progenitor cell function in both directions. So I'll show that later, but there are certain kinds of damaging progenitor cells which tend to be favored and certain kinds of beneficial progenitor cells that aren't. And these processes are tightly interlinked. So this appears to be an intervention point if this unitary hypothesis is true. So I'll focus on cellular senescence, which is a cell fate, much like replication, differentiation, apoptosis, or necrosis. So it's a cell fate. It can occur to any kind of cell anywhere in life. It occurs across the vertebrates, in many invertebrates as well. And the process is quite conserved from fish through to humans. But even some invertebrates, cells can undergo senescence-like state. Non-dividing cells can also become senescent, it turns out. This phenomenon was first described by Hayflick and Moorhead in a paper back in 1961. They showed that human lung fibroblasts in culture had a limited replicative potential. The cells didn't wind up, some of the cells didn't wind up dying. In fact, they were resistant to dying, and they sat there without dying, and they became metabolically active. They weren't believed for about 8 years. They were in the wilderness. And Hayflick is still alive today, and he's angry that he was out in the wilderness for 8 years. But before that, it was thought that cells from vertebrates were immortal. And that was based on work that was done in the 1930s and 40s growing chicken heart cells in a guy's back garden. I won't say what his name is, but he had a hut in his back garden. And back then, the medium that they used for these chicken heart cells was chicken serum. They didn't know how to filter the serum, so they were replacing cells every time they changed the medium. So it was thought for a long time that aging occurred at the level of endocrine things like the pineal gland or immune things like the thymus, and so that's where all the focus was. So Hayflick and Moore had a long time before they convinced the world that aging occurs at the cellular or subcellular level. But senescent cells, there are pre-senescent cells as well, and the field has forgotten about that. So there are cells that have limited remaining replicative potential, but they resemble in a lot of ways senescent cells, and as their replicative potential further decreases, they develop these characteristics. And as I mentioned, non-dividing cells like neurons, cardiomyocytes, and so forth can also become senescent, it turns out, or at least have some features of it. So senescent cells tend to be larger than other cells. They've got changes in their nuclear and cellular membrane. They're metabolically very active. They're resistant to dying. There are many things like other cell fates that can drive a cell to become senescent, at least 70 or 80 things. And a cell takes a combination of these factors and makes a fate decision. Do I become apoptotic or undergo necrosis? Do I become senescent? And so signals are integrated and a cell makes a fate decision, basically. Senescence, unlike other cell fates, takes a long time to develop, at least in vitro, anywhere from a week to 6 weeks plus. So it's a slowly developing cell fate after the cell fate decision's been made. There are multiple transcription factor cascades that can enforce senescence. The most well-known are the P16 retinoblastoma pathway and the P53, P21, but there's a P27 pathway and several others. So not every senescent cell is an increase in P16. Not every senescent cell is an increase in P21. In fact, there are no fully sensitive and specific markers of senescent cells. The only thing that remains to this day that people don't do because it's laborious is plate dilution cloning and ask, will a cell sit there for several weeks and not divide and stay alive? Beyond that, there's no fully sensitive and specific assay. People talk about senescence-associated beta-galactosidase, like I showed on that previous screen. It's about 2/3 sensitive and 2/3 specific. So activated macrophages have increases in SA beta-gal, for example, senescence-associated beta-galactosidase. So it can be rough to call a cell senescent, and we generally like to see 3, 4, 5, or 6 things, and then it's a judgment call, and there are shades of gray here. Most senescent cells develop something called a senescence-associated secretory phenotype, but it's highly variable. The factors in it are extremely variable and regulatable. So the nature of the senescence-associated secretory phenotype, or SASP, depends on the cell type that became senescent, the inducer, how long the cell was senescent, and the microenvironment. And it can change from hour to hour. It's highly regulatable. And there are several pathways that are involved in mediating what kind of SAS develops and its quality. The main ones including an NF-kappa B related series of pathways, another being C-gas-STING, and there are others. So around 30 to 70% of senescent cells have a tissue destructive SASP. The other 30 to 70% have a pro-growth SASP. But it's highly variable, and these cells can switch, much like macrophages can go from an M1 to an M2 state. And it appears that the secretory phenotype is what is upstream of some of the phenotypic effects of senescent cell accumulation. I mentioned before senescent cells are very resistant to dying. There are at least 10 pathways now that they can use to do this. I'll go into more detail about that. So I mentioned that senescence can occur at any point during life. It turns out that one of the contributors to childhood asthma in kids from age 2 to 4 is related to neonatal hyperoxia, where oxygen is delivered shortly after birth, and that drives cellular senescence in the lungs. And it turns out that one of the components of childhood asthma is cellular senescence related to resuscitation at around birth. So these processes can occur throughout life. Senescent cells accumulate, for example, even in children in the context of obesity and diabetes. So if you look at younger individuals, I know as senescence-associated beta-galactosidase isn't great, but if you do fat biopsies from younger individuals with an increase in BMI and some insulin resistance, you find senescent cells not only along blood vessels and multiple cell types in blood vessels, you also find the adipocytes themselves exhibit some features of senescence. Whereas even elderly individuals who don't have insulin resistance and aren't obese can have sometimes very few senescent cells in their adipose tissue. With natural aging, there tends to be an increase in senescence, but very healthy elderly individuals, you find there aren't a lot of senescent cells in their tissues. But even in very healthy elderly individuals, for example, kidney transplant donors, where a grandparent is donating a kidney to a grandchild, we looked at perinephric fat, and these people are healthy enough to donate a kidney, so they're pretty healthy people. We still see somewhere between 60 and 80 some increase in senescent cell burden, but it's not dramatic. To fulfill cost postulates, you can add senescent cells or take them away. If you transplant senescent cells into mice, so you take autologous ear fibroblasts from a mouse, you radiate it or not, or use chemotherapy or not to induce senescence, and you transplant those cells back into the mouse from which you got the ear fibroblasts, you can induce a lot of conditions with the transplanted senescent cells compared to transplanting autologous ear fibroblasts that aren't senescent. And there's a threshold. You have to transplant a certain number of senescent cells for some of these phenotypes to occur. So if you transplant senescent cells into the abdomen of one of these mice, their own cells that have been made senescent, you find after a couple of months, if you exceed that threshold, they develop frailty. So they have trouble hanging onto a wire, their grip strength is decreased, their gait speed is decreased. And after a lag period, they die earlier than other mice. And they die of every disease that naturally aged mice die from. So just putting a few senescent cells into the abdomen, they stay put there and you can label them so you can track them, predisposes to virtually everything that mice die of. Part of the reason for this is that senescent cells spread. So the transplanted senescent cells you can identify, they stay in the abdomen, but the animal's own cells, the recipient's own cells, start becoming senescent at a distance. So senescence spreads in both an endocrine and a paracrine manner. In a distant, it's not necessarily through hormones, but in a distant as well as a paracrine manner. The reason we feel there's a threshold, and incidentally, transplanting cells such that only 1 in 10,000 cells in the mouse is a transplanted pro-apoptotic, pro-inflammatory senescent cell is enough to induce this state. So very, very small numbers of senescent cells are sufficient to cause a lot of dysfunction. You have to transplant 1 million senescent cells into a middle-aged mouse peritoneum to achieve this phenomenon. If you put in 500,000, nothing happens. But if you put 500,000 senescent cells into an older mouse, these same syndromes develop. Or if you make the middle-aged mouse obese and then transplant 500,000 senescent cells, the phenomenon occurs. So there's a threshold effect. And it may be because the rate of spread of senescence can exceed the ability of the immune system to clear these cells. The senescent cells are normally cleared by the innate immune system, especially natural killer cells. They seem to be the leader. Janet Lord showed that, and others. They can also be cleared by macrophages and certain other, and then there are adaptive immune cells that can clear them as well, especially in the case of cancers. But it's mainly natural killer cells. So the belief is that when the rate of spread of senescence exceeds the ability of the immune system to clear senescent cells, you get a takeoff, and you get these syndromes occurring. And then above a threshold, senescent cells start damaging the immune system. So they produce factors that interfere with macrophage diabetes. IL-6 will do that. They produce factors that cause fibrosis around them, shielding them from the immune system. They produce factors that have an impact on dendritic cells like mitochondrial DNA. And they produce a range of factors, IL-17, IL-20, that induces IL-23 in T lymphocytes and results in T lymphocytes not effectively clearing senescent cells, the CD8 T lymphocytes. Incidentally, the SASP comprises not just proteins and peptides, also bioactive molecules like bioactive lipids and all kinds of other things, as well as a lot of non-coding nucleotides like microRNAs, circular DNA, mitochondrial DNA. Senescent cells shed exosomes like crazy and mitosomes and all kinds of other particles, but they also produce cell-free DNA and RNA species in conjunction with argonaut. They're not undergoing apoptosis, but they export argonaut with these things that partly are responsible for conferring senescence on other cells. So Ned Sharpless, who has recently stepped down as director of the National Cancer Institute, came out with a paper back in 2004 in Journal of Clinical Investigation showing that senescent cell burden increased with age in mice, and that the extent of the increase could be delayed by caloric restriction, which is something that can increase health span and lifespan in mice. So he showed an association. So when Tamara Ciccone and I were in Boston, we started from 2004 trying to figure out if this association that had been shown is causal. And so we started trying to make senolytic agents. We got nowhere for a long time. We worked with Jack Murphy at Harvard, who developed the first fusion proteins to try to make antibodies that would bind to senescent cells and carry a toxic cargo. We got nowhere. We worked with Scripps to try to develop high throughput screens, got nowhere. Then it hit us after moving to Mayo, along with Izu, who was in our lab then. In May 2013, that 30 to 70% of tissue damaging senescent cells are killing cells around them, but they themselves are surviving, much like certain kinds of leukemia or B lymphomas. So that led us to ask, are there pro-survival pathways that defend those senescent cells that are tissue damaging from committing suicide? And we had proteomic data on senescent versus non-senescent cells. We worked with a guy, Jonathan Ray in Oklahoma, who had 7 Cray computers linked up to each other. And we asked whether there's evidence based on proteomic data for upregulation of pro-survival pathways. We came up with a network of them. We call them SCAPs, senescent cell anti-apoptotic pathways. As I mentioned, there are at least 10 of them now that have been found. They're interlinked in a network. And much like certain kinds of cancer cells, they defend these cells against the things that they're using to damage tissues. So we used RNA interference approaches against key nodes in this SCAP network. And we found that interfering with certain kinds of RNAs related to these nodes would allow the 30 to 70% of senescent cells that are trying to cause apoptosis in other cells to instead die, and left the other senescent cells alone that are producing growth factors like Groin alpha or PDGF-AA. We found that different kinds of human senescent cells depend on different SCAP pathways for their survival, and in some cases they're redundant. So human mesenchymal cells, like preadipocytes, tend to depend on ephrin dependence receptor-related kinases, like the Src kinases. That dependence receptors are receptors that if they're not occupied, they'll kill a cell. You're all aware that one of the ways you treat prostate cancer, for example, is by dropping testosterone, or breast cancer by dropping estrogens. That's because if those receptors are unoccupied, they will kill the cell. The same is true of ephrin dependence receptors in mesenchymal cells. They're the things that tell a cell that I'm connected to another cell. If you dissociate a mesenchymal cell from other cells or matrix, it'll die, and it's because of these receptors. So targeting the Src kinases, the ephrin-dependent Src kinases, appears to kill senescent fat cell progenitors, preadipocytes, MSCs, people have different names for them, whereas human endothelial cells depend a lot more on the BCL family, especially BCL extra large. But other pathways as well that are related to apoptosis, like heat shock, 90 proteins, and to some extent, some of the dependence receptors. Preadipocytes also depend on SERPine-related pathways that are related to PI1, PI2. But every kind of cell type from different species, depending on how the cell was made senescent, depends on different pathways, and in some cases they're redundant. So we again went back, and using these RNA interference data, we used programs available back in 2013 from the Broad Institute to look for known molecules that could be administered to humans that had a safety profile or that were natural products and had short elimination half-lives. I'll go into the reason for that in a moment, that would target key nodes on these networks. We predicted that dasatinib, which is unlike other tyrosine kinase inhibitors, it inhibits Src kinase. Things like imatinib are not senolytic for preadipocytes, for example, because they don't target the Src kinase. So dasatinib targets like 146 kinases, but we went after it specifically because of this. We predicted it would kill the 30 to 70% of senescent human fat cell progenitors, or MSCs, that are senescent, and not HUVECs, not endothelial cells, and that turned out to be the case. Another drug we looked at early, and incidentally we found 40 drugs that would do this using this bioinformatics approach. They all turned out to be senolytic for one or another cell type. But the other agent we looked at early is quercetin. It's a natural product. It's what makes apple peels taste bitter. It's a flavonol. It's in the flavonoid family. It's a flavonol. It's the flavonols and the procyanidins in the flavonoid family that tend to be senolytic. Flavanols and other things are not. But we predicted it would kill senescent endothelial cells because of the things it targets, and that it would not kill senescent mesenchymal cells, and that turned out to be the case. The combination killed both cell types, but does not kill all cell types. And in some cases, there are cell types that are responsive neither to dasatinib alone nor quercetin alone, but if you combine them, Paul Robbins showed this in the case of MEFs, mouse embryonic fibroblasts, you do kill them. So that shows that these pathways can be redundant, and sometimes you have to use multiple agents to target a senescent cell because of this redundancy. So this is what the combination of dasatinib and quercetin targets. And since then, using that original hypothesis-driven approach, we and others have found many, many more compounds that are senolytic in cell culture, human cell culture, human tissue or animal models. And since then, high-throughput assays have been developed, and also vaccines and CAR-T approaches. I worry about those, though, because you can't turn them off. CAR-T approaches you can, but vaccines you can't. So senescent cells are necessary for a lot of functions. They're necessary for embryonic development. They're necessary in that they accumulate in the placenta, and they produce the factors that drive the baby through the birth canal in the last 5 days of pregnancy. They're important as a defense against cancer. So you don't want to prevent senescent cells from forming, or you will cause cancer. You knock out P16 or P21 or RB or something in an animal, it'll be full of cancer very quickly. What you want to do is get rid of persisting senescent cells that aren't gotten rid of by the immune system, because over time they become more and more pro-inflammatory. After a couple of months, they start having line 1 transpositional events. They mutate like crazy, and they can escape senescence, and they escape senescence as cancer cells. So the idea is to get rid of persisting senescent cells. I mentioned before that it takes a week to 6 weeks for new senescent cells to form. That's why we wanted drugs that have a short elimination half-life. So these cells don't divide, so once they're gone, they're gone. But we want to use a hit-and-run approach to kill these cells, much like you might with a urinary tract infection, where you can give a single dose of antibiotics. You're rid of the bacteria, then you don't have to go back again. But unlike bacteria, senescent cells don't divide. So when you're rid of them, you're rid of them, unless there's an impetus for new cells to form. So we're after a network of molecular impacts. We're not using the one drug, one target, one disease approach here. This is much more like developing antibiotics. We were talking earlier. It's a division of the FDA that's involved in developing antibiotics that works with us. Because we're not trying to develop an antihypertensive where you've got one drug, one molecular target, and one disease you're looking at. This is much more like antibiotics where you may have, in some cases, 4 or 5 antibiotics to go after a resistant bacterium. It's the bacterium you're after, and you're after multiple diseases. It could be urinary tract infection, meningitis, endocarditis, skin infection. So much the same way of thinking. And we constantly have to battle with some people on study sections who are married to the concept of one drug, one target, one disease. So if you transplant senescent cells and have them expressing luciferase so that you can see them with a light signal into mice, you kill the 30 to 70% that are senescent with oral dasatinib and quercetin in a single dose. The other reason we chose to pick particular agents is not only that they'd been on the formulary and we knew their safety profile, but that they're orally active, because we wanted to move to clinical trials. Transplanted non-senescent cells are not killed by this combination of agents. If you take human fat tissue, put it in a dish from obese, diabetic, younger individuals with incipient renal failure, you see a lot of senescent cells. You can keep the fat tissue alive for at least 72 hours. So you can do time courses and look at senescent cell removal. It just takes 2 hours of exposure to senolytics to initiate irreversible apoptosis in senescent cells. And it may be less. We've only looked down to 2 hours. The apoptosis takes 18 hours to complete, but once it's started, it's started. So this is another argument for using a hit-and-run approach. And this just shows that you clear the senescent cells from these human fat tissue explants. This is after the clonal plate dilution assay, probably the most sensitive and specific assay. It's about 90% sensitive and specific, but it's not perfect, and it's called telomere-associated DNA damage foci. So you look for DNA damage foci within telomeric ends, and then you can count up a certain number of chromosomes that have this and a certain number of DNA damage foci per telomere. And, you know, there are cutoffs, but I don't know that those cutoffs are real. There's always sort of shades of gray. If you radiate the single leg of a mouse such that the hair on its leg goes gray after a couple of months and it has trouble walking on that leg, if you give a single dose of senolytics, you restore its ability to run on a treadmill for the remainder of its life, because there's no further radiation given to the animal, so there's only one wave of senescent cells, and you take them out and they're gone. So that is another argument that we use in the clinical trials for using a hit-and-run approach and giving these agents intermittently, depending on how senescence is being driven. Remembering it takes a week to 6 weeks for these cells to reform if there's a continued stimulus. We showed that Jordan Miller, working with us, one of the first phenotypes we showed was in aging mice is that we could clear these cells in the cardiovascular system and get improved vascular reactivity to acetylcholine, nitroprusside, and so forth, and some improvement in ejection fraction in older animals. We found that we're able to reduce intimal calcification in ApoE, high-fat fed mice. We found that we're able in very old mice, because mice, unlike rats and humans, don't get much frailty until the very, very end of their life. So rats and humans get it in the last 20% of their life in some cases. Mice, it's very late. But those mice that have physical dysfunction, say 24-month-old mice, which are equivalent to 80-year-old humans, and if you select the ones that have frailty, then you can show that giving one dose of senolytics orally every 2 weeks for a period of 4 months alleviates a lot of their frailty. Sandeep Khosla, working with us, showed that we're able to increase both cortical and trabecular bone mass in the case of age-related osteoporosis. And the mechanism is, because these fundamental aging processes are interlinked, is on the progenitor cells, or some people would call stem cells, that relate to bone function. I mentioned stem cells can go in both directions. So osteoclasts are cells that degrade bone. They're related to macrophages. And osteoblasts are cells that make bone. With aging, and if you expose animals to cells, I should say in vitro, to senescent cells, the SASP of senescent cells accelerates osteoclast differentiation, the cells that break down bone. And if you expose osteoblast progenitors to senescent cell conditioned medium, you decrease their formation. So you've got these two things going in opposite directions. The cell, in other words, senescent cells will drive formation of cells that break down bone and prevent formation of cells that make bone. And senolytics do the converse. So if you administer senolytics, you get a decrease in bone resorption and an increase in bone formation. Certain bisphosphonates, if administered the right way, like IV zoledronate will do this too. It turns out it's senolytic. But oral bisphosphonates don't. They only decrease bone resorption, and there can be a coupled decrease in bone formation along with that. In the case of peripheral insulin resistance, again, mice don't get diabetes. They've got a gigantic pancreas, but they can get insulin resistant. You can show that in older, rats do get diabetes in the last 20% of their lifespan, mice don't. But you can show that at least the peripheral insulin resistance in mice measured by insulin tolerance testing or clamps or so forth. You can reduce that in obese or aging mice with intermittent treatment with senolytics. If you transplant adipose tissue from obese diabetic humans and into slightly immune deficient mice, these SCID mice, you induce diabetes-like state in them. You don't get necessarily an increase in blood sugar, but you get insulin resistance. And if you treat those mice with the transplanted human senescent cells, you alleviate peripheral insulin resistance. Senescent cells, those that are pro-apoptotic and pro-inflammatory, attract, activate, and anchor various cells of the immune system. So senolytics don't directly kill those immune system cells. What they do, it turns out, is they kill the senescent cells that activate them. So if you inject monocytes that are labeled into the tail vein of mice that are obese, those monocytes tend to track to their adipose tissue where the senescent cells are. They become activated. They turn into M1 macrophages. If you treat those animals with senolytics despite continued high-fat feeding, the monocytes no longer track to adipose tissue. You're not killing macrophages. You're preventing them from having signals that make them go into adipose tissue. Senescence spreads, as I mentioned. So if there's a focus of senescent cells, say an osteoarthritic knee, we're finding with the people at Johns Hopkins that you get senescent cells in the brain. And that correlates with the abundance of senescent cells in the knee. And it's looking like people with osteoarthritis, for example, severe osteoarthritis, are getting things like Alzheimer's disease earlier than other populations. So there tends to be spread. And one example of this is in the context of obesity. Many individuals with obesity have neuropsychiatric dysfunction, anxiety, or depression. Mice get that as well. So if you either high-fat feed them or use genetically obese mice, you tend to find senescent cells form in the ependema around the third ventricle. They produce factors that cause neuroinflammation, increased gliosis, decreased microvascular circulation, and other things that occur in the brain. And the third ventricles are pretty close to the limbic system. So if you give senolytics, you restore neurogenesis. You actually get new nerve cells forming. You decrease gliosis or fibrosis in the brain. You improve microcirculation. You get rid of calcification and so forth. And you decrease anxiety. So you can measure anxiety in mice because they're afraid of open spaces. That's why you put mouse traps around the wall, because they're afraid of predation by birds. Mice that are obese are especially afraid of open spaces, but you can restore their, decrease their anxiety by administering intermittent senolytics. Several groups, including a group in San Antonio, just down the road from you, and a group at the NIH found in various models of mouse Alzheimer's disease. They're all bad. They don't really recapitulate Alzheimer's that well, but one of the better ones are these tau mice that get an Alzheimer's-like state when they're 22 or 23 months of age. But they looked at 5 different models, and they found that senolytics would actually reduce protein aggregates in the brain, amyloid or tau-like particles. And amyloid and tau can drive cells to become senescent, by the way, and it also appears senescent cells produce amyloid, tau, and alpha-synuclein. So these fundamental aging processes are tightly interlinked. They found decreases in those. They found decreased neurofibrillary tangles, decreased gliosis, improved circulation in the brain, decreased ventricular shrinkage. In fact, decreased ventricular enlargement. They found the ventricles actually shrank a bit, and they found neuronal growth in the frontal pole and the hippocampus of mice, and that was associated with improved memory and executive function. So that's the basis of the clinical trials currently underway for Alzheimer's disease with senolytics. I mentioned before that the SASP is highly variable. So pathogen-associated molecular profile proteins or damage-associated proteins factors can make the SASP of senescent cells worse or cause cells to become senescent. So in the case of lipopolysaccharide that's produced, for example, by gram-negative bacteria, that exacerbates the SASP of existing senescent cells. So if they're the good guy senescent cells that are producing growth factors, it can make them become pro-inflammatory. And the same thing with gram-positive signals with fungi and with RNA and DNA viruses. So in the case of coronavirus, for example, if you have senescent cells in neighboring non-senescent cells, they will cause an increase in ACE2. They will also interfere with innate viral defenses like IFIT M1 and 2 that are innate antiviral defenses in neighboring non-senescent cells. Furthermore, they produce factors that interfere with antibody responses to vaccine. And So if you infect mice with a virus related to human coronavirus, because mice don't have ACE2 receptors, if you use something called mouse hepatitis virus, which is a related virus, you can cause young mice don't die with this virus. Old mice die within 10 to 12 days, much like old humans with coronavirus are more susceptible. If you either genetically remove or using tricks that we developed after we started working on senolytics, like the Incotac mice, or if you use different kinds of senolytics, you can reduce the risk of these mice dying. It turns out that viruses can cause cells to become senescent. This is through, in the case of RNA viruses, through TLR3. In the case of DNA viruses, it's through, TLR2, 4, 9, et cetera. Viruses preferentially infect senescent cells. They're 3 times more likely, in the case of coronavirus, to enter a senescent than a non-senescent cell. Furthermore, Clement Schmidt at the Charité in Berlin showed that it's in senescent cells that viruses mutate. So senescent cells, as I mentioned before, have a lot of things going on with respect to nucleotides. And not only nuclear DNA gets mutated, but pro-RNA species in the nucleus do, and then cytosolic, mitochondrial DNA and RNA can be mutated in senescent cells. So there's an emerging theory, and it's only a theory at this point, that a lot of the variants of things like coronavirus are arising in senescent cells. Senolytics prevent and alleviate dysfunction caused by transplanting senescent cells into mice. Those experiments I showed you before, so oral senolytics will do that. They reduce the frailty that's caused by transplanting senescent cells. If you transplant hearts from old to young animals, compared to young animals, we did this work with Stefan Tullius, he's chief of transplant surgery at the Brigham. If you transplant hearts from old animals to young animals, you find the young animals' own cells start becoming senescent, much like those earlier transplantation studies I showed you. So in their livers, they start developing senescent cells, and it's their own cells. The senescent cells produce mitochondrial DNA that activates dendritic cells in draining lymph nodes and provokes graft versus host reaction. If we treat the donor of the hearts themselves, or the recipients of hearts from older animals, we can partially alleviate this effect. So there are trials underway now of trying to rehabilitate organs from older donors in life port systems and other things like that, so that they could arguably be used for transplanting younger individuals. At the moment, the transplant surgeons tend to throw away kidneys from non-related donors, people who die in car crashes and have signed donor cards, if those donors are over 50, because they've known for many years that those organs, even if the organs look good, they don't do. So we're throwing away 35,000 kidneys a year in the US, simply because they're coming from older individuals. And in many cases, they look functional, but there are problems after you transplant. The same with livers, hearts, and so forth. So we're trying to figure out, while they're on the life port system, given that senolytics only take 2-hour exposure to start killing senescent cells, can we rehabilitate organs from older donors? Don't know that yet. But there are at least 70 conditions now that it appears senolytics can delay, prevent, or alleviate. And I could say the same thing about these other geroscience interventions, like NAD precursors or metformin or rapamycin, and they act as what we call xenomorphics. They inhibit the secretory state of senescent cells. Rapamycin only inhibits the protein part. Metformin inhibits the entire thing, including the DNA part, by its effects through mitochondrial complex 4. And then there are other agents that are what we call xenomorphics. They, unlike senolytics, have to be given a bit more continuously, because you're trying to inhibit the secretory state of senescent cells. Senolytics get rid of the pro-inflammatory senescent cells in the first place. So we can't actually give xenomorphics at the same time as senolytics. So in the clinical trials, we have to stop metformin a couple of days before we give senolytics, because things like metformin or rapamycin prevent those senescent cells that are producing bad things from being able to commit suicide. So we have to have the senescent cells actually angry for senolytics to work, because they disable pro-survival networks. So one of the things that got founded, and we're having to do a competing renewal, which I dread, in July, is this translational geroscience network. And it brings together, at the moment, 8 institutions. There are more joining, where we're trying to do clinical trials in parallel rather than in series across a range of conditions and comparing geroscience interventions. And what we have is sort of common approach to the regulators. We try to do multi-center trials. We have a group at Wake Forest that does the statistics. We're biobanking samples at the NIH Biobank in Frederick. And then we're trying to use similar protocols across trials as far as things like cognitive function testing, as well as looking at, and I'll talk about it in a moment, various body fluid tests and so forth, and other kinds of tests. So a very early trial of Senolytics was a phase 1 with all the problems that these trials have, trial of Senolytics in idiopathic pulmonary fibrosis, which is a fatal senescence-driven disorder. The main reason people with that condition die is related to frailty, not shortness of breath. And they get severe frailty. The trial, I'd emphasize, is open label. There could be learning effects. It's uncontrolled. There could be all kinds of garbage behind this. That's why we need to do a phase 2A trial. But it looked like a few doses, 9 doses over a 3-week period of Senolytics, arguably, appeared to improve 6-minute walk distance, 4-meter gait speed, chair stands, and the short physical performance battery. We did a trial to look at target engagement, in this case with dasatinib and quercetin. So we gave 3 doses of dasatinib and quercetin on days 0, 1, and 2 to obese diabetic younger subjects who had incipient renal failure, much like the picture I showed you earlier. Dasatinib has a 3-hour elimination half-life, so it's completely gone from the body within 9 hours. Quercetin, it's 11 hours, so it's completely gone from the body by 33 hours, 3 half-lives. So we did a second biopsy 14 days after the last dose, at day 14, which is 11 days after the last dose of Senolytics. So the Senolytics are long gone. You know, we've just given a very small, short time frame bolus of these agents. And we found some evidence that senescent cell burden appeared to be decreased in adipose tissue of these subjects, looking at P16 and senescence-associated beta-galactosidase. There was decreased activated macrophages. You know, I showed you before that these cells attract, activate, and anchor innate immune cells. And there was decreased fibrosis in their adipose tissue as measured by crown-like structures. And that's where a lot of senescent cells are focused, is within these crown-like structures. So one of the things being developed through the Facility for Geroscience Analysis, which is part of the Translational Geroscience Network, is what we call gerodiagnostics. We're not interested in biological clocks. You know, the best biological clock I have is my birth certificate and a wall calendar. Who cares, in a way? What we're interested in, what CLIA's and the FDA are interested in, if we want to create an endpoint for a surrogate endpoint for clinical trials like fasting glucose or blood pressure, for example, so we don't have to do 50-year-long clinical trials, is composite scores of markers of various types from body fluids that not only track with, as it were, biological age, but are sensitive to interventions, tell us which pillars of aging are operative. You know, so we're looking for all the various, not just senescence, but every pillar of aging we can measure in body fluids. And where those things respond in the appropriate direction with interventions like GDF-15 doesn't. You know, people talk about GDF-15, which goes up with frailty, but it goes up even more if you calorically restrict an individual, put them on metformin, or make them do exercise. So that's not the kind of biomarker we're after, or gerodiagnostic. And then we want to find gerodiagnostics that will precede clinical improvement. And then the things have to be reliable, reproducible, all of that stuff. So the FDA has 9 criteria that have to be met. We've had a number of meetings in Washington and a series of steps. Some of those papers will be coming out with the NIH and the FDA to try to come up with how to do this. So I mentioned in the FDA, there's the Facility for Geroscience Analysis. It's part of the Translational Geroscience Network. So body fluid analysis is done for all these trials that are going on in the same place. And they're done blinded. So an early composite score we came up with was in those patients with, the first composite score was in the patients who had diabetes, who had, blood drawn at day 0 and day 14 in that trial I talked about of 3 days of Senolytics. And David Allison at University of Indiana, he's the guy who came up with the Wang-Allison test, which every actuary uses nowadays for survival. He's dean of University of Indiana. He's very smart, geriatrics statistician, writes his own code. He came up with with this early score, and that seemed to improve in the patients and tracked with senescent cell burden. Later on, we've come up with something called Sen-Mayo, which is for looking at tissues and a composite score. So I mentioned these processes are interconnected. One of the things is that's interesting is alpha Clotho. We were talking about it last night. It's named after the Greek fake goddess Clotho, who is, was discovered more than 25 years ago. She's the one who holds up the spool of life and is the goddess, the fake goddess of pregnancy. Atropos is the one at the other end with the knife cutting the, that kills you. And that atropine got named after Atropos. That's because the Greeks used belladonna on their arrow tips to kill their enemies. But Clotho you see in cemeteries looking down at the dead because she's supposed to be able to raise the dead to the afterlife. So Clotho, if you overexpress it in mice, results in a substantial increase in maximum lifespan and health span. It goes down with aging in mice. It's produced especially in the brain, the kidneys, and fat tissue. As I mentioned, if you overexpress it in mice, there's preserved function. If you decrease it through various means in mice, there's accelerated dysfunction. And we found that in 20 out of 20 patients with idiopathic pulmonary fibrosis, given senolytics, their urine alpha Clotho went up. You can only measure it in the urine because the blood assays are no good. It's gigantic protein and all kinds of interference. People have been looking for ways to do this because the protein is sticky and gigantic, and you'd have to give it IV and get it to places like the brain. It's impossible to do at the protein level. But it looks like because these processes are interlinked, senolytics may work towards that direction. We found that the increases in alpha Clotho were inversely related to pro-inflammatory factors and matrix metalloproteinases in the urine. So what we're looking for are things that go up that are bad and things that go down that are good, so we can express things as a ratio. So, bad things that go up, and then geroprotective agents like Clotho that go down with age. And then, as I mentioned, that we're not dealing with expressing things as a function of creatinine or something, which screws everything up. So the clinical trials, we're looking at risk-benefit ratios. It's only very sick people with advanced disease we're enrolling because we don't know what all the downsides are. There are a lot of clinical trials underway. 16 of them are with senolytics, and they range from trials with St. Jude's, looking at childhood cancer survivors, because they found that senescent cell burden correlated with this state that childhood cancer survivors can develop in their 30s, where they're dying of Alzheimer's disease, diabetes, osteoporosis. They look like they're 70 when they're 35. They've got over 800 of these people. And the severity of that syndrome correlates directly with senescent cell burden. So the NCI has funded a trial where we're comparing two different kinds of senolytics, fisetin on the one hand and dasatinib and quercetin on the other to placebo, and that trial started. There are trials for frailty, 3 trials for Alzheimer's disease, 1 for mild cognitive impairment. There are trials for obesity and diabetes. There are trials planned but haven't started for Down syndrome, a phase 2A, for idiopathic pulmonary fibrosis, and the list goes on. One of the interesting things is that it looks like astronauts have increased senescent cell burden. So we've been working with Axiom and SpaceX to try to look at this. Had to go to Cape Canaveral, watch a launch, got pretty well blown over when the thing took off. So we're trying to figure out, we know working with Brookhaven that very small doses of equivalent to cosmic radiation with atoms going at light speed instead of photons or electrons, helium, hydrogen, selenium, in the periodic table. It takes a much lower dose to cause cells to become senescent. Just 0.5 grays is enough. Where X-rays or gamma rays, it's 20 grays. So if this is true, can't go to Mars unless we can sort this out. So in conclusion, persistent senescent cells especially, the ones that have been hanging around for more than a couple of months and are pro-inflammatory factors, appear to cause inflammation, fibrosis, progenitor cell dysfunction, spread of senescence, and are related to multiple, both acute and chronic diseases throughout the lifespan. The target of senolytics is senescent cells. It's not a single molecular pathway. So the FDA wants us to show in patients or disease states there are senescent cells. Why would you give a senolytic to someone who doesn't have senescent cells? Senolytics appear to attenuate tissue inflammation and fibrosis and improve function. They reduce rejection after transplantation in the case of preclinical studies. Hit and run intermittent approaches appear to be as or more effective than continuous dosing. There's a way of reducing off-target effects. The drugs are only present for a few hours a month. You're not continuously occupying a receptor or affecting an enzyme. And they appear to delay or alleviate multiple conditions in mice. But we don't know in humans yet. I spend half my time telling people not to take these drugs. Don't buy them over the counter. Don't prescribe them. We have to do the clinical trials. Anything that sounds too good to be true usually is. We expect most of the clinical trials will fail. Even the best agents in a phase 2A trial have a 5 to 10% chance of working. And that's why we're trying to do multiple trials, and we're trying not to raise public expectations. In fact, we're saying to people most of the trials will fail. And that's why we want multiple shots on goal until we get this right. So I'll just conclude by thanking a lot of people and funding agencies for help with this. Thanks.
Spectacular. Stay here, James. I think there's going to be some questions. What a spectacular talk, huh? I mean, all the way from the fundamental molecular mechanisms of senescence all the way up to understanding of senolytic agents and application in clinical trials.
Caution, we don't know if they work. I've gone from 3 years ago from a 0.001% chance they'd work in humans to a 20% chance, but there's an 80% chance they won't, I think, at this point. So I've got to be convinced.
We're going to get the questions from the audience here first, but I'd like to ask a question for you about this, the diagnostics, geodiagnostics. And I'm wondering if, with the facial recognition software and AI, we could just look at somebody and kind of estimate what their physiological age is.
Yeah, and some of those things reverse. So there are a lot of things that are being done in some of these trials, and also these healthy longevity clinics that are being set up around the world. One of the first ones was in Stanford, another in Singapore, but they're being set up, a couple of them at Mayo, at Harvard, Oxford. A new one's opening in Israel in July, and in Saudi Arabia, et cetera. The idea there is to give evidence-based advice to people and mainly tell them not to take things. And then where there's a justification, a medical justification, maybe get them onto metformin or SGLT1 inhibitors, or, and there are certain other agents that, actually cardiac glycosides are senolytic, IV zoledronate. So there are things you could push people towards provided there's an indication, but we're trying to measure things in these clinics across. So we're looking at AGEs, advanced glycation end products, and that's a fluorescent assay of the skin where you just put your arm in a thing, and after a couple of minutes because hemoglobin A1C is an example of this. One of the things that occurs with aging is reducing sugars reacting with amino groups, and this is related to senescence and all these other fundamental processes. Facial recognition, as you mentioned, it can be done within under a minute. The most primitive way is to use 5-angle cameras, but now there are devices that will measure it, so you can get an idea of hair growth, wrinkling, and all kinds of other things that occur with respect to facial recognition. Saccadic eye movements in response to visual stimuli, so there are masks that you can put on people, and again, within a couple of minutes, You can prescribe wearable devices that after a couple of weeks, you can see what sleep-wake cycles are like, what activity is like, and body temperature fluctuations, et cetera. Those are useful. ECGs are very useful. As you know, you can predict the sex of an individual with 99.5% certainty from a 12-lead ECG using AI approaches.
I did not know that.
And it's turning out that some of these, you can predict some of these things downstream, just from a 12-lead ECG. There are 2-lead EEGs that you can use very quickly. So there are a whole lot of things that we're trying to develop in unison across these clinics. And we're trying to use the same body composition sort of measures, and that can be done quickly. Gait speed and that can be done with laser methods now, where you don't have to have marks on a floor, and you can do it very fast and very reliably. So I think around the world there's an effort to harmonize which devices and equipment, and also what questionnaires are used, like of cognitive function and physical function.
Spectacular. Dr. Taffet.
Yeah, Jim, thank you so much. What are the differences between senescence that's produced by radiation and senescence that's produced by aging?
Well, as I mentioned, there are 70-plus things which can tend to push a cell into senescence, and the nature of senescence depends on the cell type that became senescent. It's like differentiation. Like a differentiated fat cell is different from a differentiated neuron or cardiomyocyte. The inducer of senescence, how long the cell has been senescent, and its microenvironment. So these features are highly variable, and people forget that they're pre-senescent cells too, and they're shades of gray. And it's really hard to call a cell senescent. You know, you'd have argument between people about that. So we have to live with some uncertainty at the moment. There's no single marker that will tell you that a cell is senescent for sure, unless it's a replicating cell type that you do clonal plate dilution. That's the only time you can really do it.
Dr. Zogby?
James, really an eye-opener this morning. The depth and breadth of these investigations are, I think, will be a game changer, no question about it. I know you're
touching wood. I don't
your,
know.
I know your forecast is, aim low. Hopefully, you'll get something high, but it really is amazing. Couple of questions for it. One is, I'm a bit confused of how do you identify senescent cells? I mean, you mentioned a lot about their properties. The question is, how do I identify them? What are their characteristics, at least physically? One. Two, are they evenly distributed in the body? In different organs, how are they? Three is, do they conceivably, their difference, concentration, et cetera, account for, I know you don't care as much about chronological age, but do they account for the differences in the human species? Not even human, in the living species. If you take a look at a dog or a mouse or a human, to me, an intriguing thing is organs are rather similar. Heart rate may be quite different. Why is the longevity so different? Is it because of senescence or other mechanisms?
Well, in answer to the last question, it's all of the mechanisms have been linked in many species. All of the fundamental aging processes, including senescence, have been linked to lifespan for what it's worth, but lifespan is not a useful clinical parameter, it's more health span. With respect to calling a cell senescent or not, it's very difficult to do, so we look at the morphology of the cell, for example, and lamin and how it's distributed, whether there's blebs from extracellular vesicles being formed. We look at telomeric DNA damage foci. We look at unfolding of chromatin around the centromeric area. We look at what do the mitochondria look like. They tend to be many of them, and they're dysfunctional, and there's a Warburg shift, much like in cancer cells, so they utilize glucose and not fatty acids. We look at things like senescence-associated beta-galactosidase, which tells you about lysosomes. We look at some of these transcriptional regulators that may be increased in at least some kinds of senescent cell, and we look at their phenotype, and it's a judgment call. And you have to integrate these things, and you'll have two people saying different things about whether that cell's senescent. So you have to really, if you're doing pathology on them, you have to do it blinded. So we use composite scores now, like this Sen-Mayo score. With respect to which cell types become senescent first, it depends on the individual, the disease state, and what's going on.
So it could be regional.
Well, if you find senescent cells in one place, they tend to be everywhere. But there can be more of them in some places than others. You know, with Johns Hopkins, we've been finding that, as I mentioned, that the number of senescent cells in the knee joint that you remove at the time of surgery for osteoarthritis correlates with markers of senescent cells in the CSF because you're using spinal anesthesia for that procedure.
And with respect to the cardiovascular system, there are areas of focal senescence in the cardiovascular system. So in the vasculature, it bends, branches, and bifurcations. You
Right.
have accelerated aging, which may explain, in fact, why you get lesions there.
Mechanical and shear stress can drive senescence by deforming lamins. So that's how you get it in osteoarthritis. That's how you get it in renal dialysis fistulae. On the venous side, Carl Nath showed that, and why they clot off because they're producing serpines and so forth. And you know, they only last for 6 months to a year. But if you treat animals with senolytics with AV fistulae, you can greatly lengthen the time that they work. And then as you were mentioning at bifurcations like in the carotids, coronary vessels, and the senescence tends to also drive calcification and fibrosis.
I think we have time for two quick questions.
Yeah, hi. So as you mentioned, like senescence can happen in non-dividing cells also. So like in the non-dividing cells, like the neurons, if the cells undergo senescence, and eliminating those cells with the senolytics, then neurons can be damaged. Is there any other way where we can reverse the senescence rather than killing the senescence?
Well, it's better to kill the cells if they're damaging, and it turns out in animals, we don't know in humans yet, that new neurons do appear later in life even. And even in things like spinal cord injury or peripheral disorders that seem like ALS and things, as well as Parkinson's and Alzheimer's models, you actually get new neuron formation. The same kind of thing in the Gina Ellison at King's College in London showed that you actually get new cardiomyocytes in older animals if you clear senescent cells. So many, many tissues have progenitors sitting there, even the ones that we think of as normally non-replaceable, where there can be some replacement. And also, senescent cells are rare. It just takes a very few of them to cause dysfunction. Like in scleroderma, there are very few senescent cells, but that really will accelerate and promote scleroderma. And that's why a lot of the dermatologists are using, or in part, they found that using dasatinib off-label will slow it down.
Yes, so thank you. Dr. Cullen, I have 3 questions. So one, as you know that cancer therapy inhibit cancer because it also causes cancer cell senescence. So do you think senescence inhibit cancer because it inhibit proliferation? Let's say P53, P16 signaling?
Yeah, oncogenes, carcinogenic mutations can drive a cell into senescence, which takes it out of the cell cycle, and then those senescent cells can kill surrounding cancer cells. And that's probably why you don't want to interfere with the capacity to form senescent cells. But if they persist, senescent cells drive cancer development. So they interfere with the immune system, they cause fibrosis, they induce don't eat me signals and don't find me signals in neighboring cancer cells. And senescent cells can escape after a couple of months, especially senescence. So therapy-induced senescent cells, we published a paper just recently with Dr. Burns at Mayo, who's a neurosurgeon, specializes in glioblastoma. We find that if you chase in animal models and cell culture models treatment for glioblastoma with senolytics, you reduce rate of recurrence. So the NCI has a call now. They had 2 position papers out in JNCI in 2021 talking about a 1-2 punch approach where you give chemotherapy or radiation followed by senolytics and then cycle them. Because radiation and chemo can drive cancer cells to die or become senescent. And you want to get rid of those persisting senescent cells because there's some argument that they can escape senescence and come back as more therapy-resistant and invasive tumor cells. There are some people who believe that most cancers, and there are some data for it, people at Sloan Kettering, for example, believe this, that many cancers go through a stage of senescence before they escape senescence and become a full-blown cancer
Yes,
cell.
so-
And you don't want to revert senescent cells into dividing cells because many of them are cancer harboring.
Yeah.
I'm
So
getting
that
the signal that we're going to have to close the discussion. Sorry about that, Dr. Lay. But Jim, thank you so much for a spectacular presentation. You really helped us understand senescence.
Well, I'd
senescence.
caution, we'll see if any of this is true.
Yes,
We don't know. And if it doesn't work in people, like, who cares?
Best of luck with your clinical trials. Thank you.